like to thank Dr. Vizzetti for helping out with this lecture, as well as Dr. David Leake, who's one of our radiologists, coming to help out with reading the images for today as well. So today we're going to be talking about back pain. So the majority of back pain, so it's a more common presentation among adolescent and adults compared to younger children. And the majority of the time, there's no definitive diagnosis that ends up occurring with these presentations. By far, it is associated with trauma, and then oftentimes the majority ends up being benign musculoskeletal in etiology. But there are other causes that you need to take into account. Again, not as common, but congenital anomalies, any infectious processes, inflammatory processes, and even neoplastic as well. And like I said, most often occurs in adolescence. So differences between adults and pediatrics. So adults, the bones in and of themselves have been ossified and then closed for the growth plates as well. So pediatrics tends to be more flexible, more elastic, and so you do end up getting more injuries to the physioplate as well as causing potential growth defects as well in pediatrics. But you also see more remodeling within the bones as they grow, and then as well a higher water content in the nucleus pulposus. So in general, they tend to be more vulnerable from a physical and growth standpoint. And then imaging. So imaging, often the first modality that's taken place with back pain is going to be plain films. So with your 2-view x-rays, looking at the spine in and of themselves. And then if you're worried about spondylolysis, so getting an oblique view to look for that Scotty dog sign. But there's other imaging that helps with better visualization. So bones, the CT, MRI, if you're looking more for structural issues that are going on, as well as looking at the neuro system as well. And then the bone scan is, since advances in MRI have just continued to improve, bone scan has become less utilized, although it still can be used, especially if you don't know if you're worried about an infection somewhere in the bone, then scanning multiple sites is where it's helpful in that scenario. And so when you're looking at x-rays of and we'll kind of go through this as in each case, but when you're kind of gauging, is there anything abnormal? Is it a normal x-ray? These are kind of the things that you are going to want to look for. Basically, is there any asymmetry? So does the shape look the same throughout? Is it uniform? Do you see the pedicles on both sides? Not only the bones and the vertebra in and of themselves, but also the intervertebral disc also, looking at the height, and then also looking at soft tissues and the paraspinal lines as well to see if everything is well aligned or is anything pushed or deviated to one side as a result of something that shouldn't be there. So case number 1, so here we have a teenage gymnast comes to the ED with a complaint of low back pain. It's been on and off for about 6 months. Diagnosed by PCP with a muscle strain, continues to have pain. It intensifies some days. The PCP just told her come to the ED. No fever, no neurosymptoms, no known trauma. Physical exam, vitals are all normal. She has some mild lower back tenderness when you have her perform range of motion maneuvers. And then this is her x-ray.
I want to point out these are selected films.
Selected films. Don't complain. That's on the record.
We started with a hard one, so let's take a shot at that.
Not yet. Does anybody see anything?
It's not connected.
That's good. Yeah, I think you can appreciate there's some absent bone in this region, the posterior elements. And also, if you follow the posterior body of L5, it looks like it's slightly anteriorly displaced compared to the posterior body of S1. And so it looks like there's a little slippage there. And so these findings are compatible with spondylolysis, spondylo meaning spine, lysis meaning defect. So we have a defect in the posterior elements. And then We have a little bit of a spondylolisthesis, spondylo meaning spine, and listhesis meaning slippage. So this is what it looks like on the plain films.
So spondylolysis, like he had mentioned in that portion of the bone, it is a defect involving the pars interarticularis, most commonly occurring in the lumbar region at L5 specifically. Pain is often exacerbated with extension of the lumbar spine is when you tend to see it, and again, most commonly in adolescents, and then more specifically in athletes, gymnasts, and other specific sports as well. But it's often the mechanism thought to be as a result of repeated microtrauma resulting in a stress fracture. But then there's also this question of, is there a genetic disposition for certain patients who also present with this? And then it is not uncommon for this to progress to spondylolisthesis, so it's always something to keep in the back of your mind in these cases. So imaging, like I mentioned before, X-ray is going to be especially in this case, is going to be your first line choice in this scenario. And then if you are thinking if it is on your differential spondylolysis, then you do want to ask for that oblique view, that's where you get your Scotty dog sign, which we'll look at here in a little bit. And then if there's any neurosymptoms or any underlying pathology, such as spina bifida or other comorbidities, then you may want to think about getting further imaging to further clarify anything going on with CT or MRI. So the Scotty dog sign, so like Dr. Leake had mentioned, the pars inter is fractured, and so whenever you have anterior slippage, that's when it progresses to spondylolisthesis. And so when you have the oblique view, Scotty dog, so the pars interarticularis is the neck, and collar sign almost looks like a collar on the dog whenever there is a fracture. Otherwise, it is congruent and intact. And then you can see that the pedicle is the eye, and then the other parts of the body that are different parts of the vertebrae. And there you could see arrows showing the head, ear, neck here, and then the body and the legs. And then you can see on this film here that you could see a collar on the Scotty dog there. And then spondylolisthesis, so anterior slippage of the vertebrae, one on the other. So case number 2, so we have a 12-year-old male presents with back pain for 2 months, fell playing soccer, no obvious injury, subjective fever for about a month, and then difficulty walking secondary to the pain. His physical exam, so he looks uncomfortable whenever you walk into the room, temperature's 101. He has lower lumbar pain with walking and with raising his legs. There's some mild tenderness along that region as well. His back otherwise looks normal. His lower extremities are equally weak, but there's no other neurodeficits. And this is what you see.
Yeah. So, generally, what?
Have them read it. We'll have them see what they say.
Okay. Yeah. What? Anybody see anything here? Right. If you look at the disc above, that's what I like to do and kind of get a visualization of what looks normal. And so you see the vertebral body, the disc, vertebral body, the disc, vertebral body, and then it doesn't look quite right there. And you can see at the disc, there's a kind of a sclerotic line called the vertebral end plate, and that's normally intact there. But when you come down to the abdominal disc, the vertebral end plate is gone, it's destroyed, and just an indistinctness of the disc. You don't see the vertebral end plates very well at all. And so this would be concerning for a discitis when you see involvement of the disc. Tumor generally does not involve the disc, and so when you see involvement of the vertebral end plates, It's a high, that points you to discitis.
And then after this x-ray, you end up moving to get an MRI. Any thoughts, Jason? This Jason? Here's a pointer on here if you like to use. I know it's a lot of things holding.
Sort of unable to distinguish increased signal attenuation.
Yeah, so it's same sort of thing that we do with the plain films. Try to look at the disc above. We see the vertebral body. This darker line is the vertebral end plate, the disc, vertebral end plate, then the body, the vertebral end plate, the disc, vertebral end plate. And then you notice the entire vertebral body shows abnormal increased signal, increased T2 signal intensity, indicating increased edema. And then when we come to the disc, the vertebral end plates are absent, they're destroyed. And again, when you see involvement of the vertebral end plates, that points toward infection. There's some prevertebral edema as well, extending beyond the vertebral body, and there's some extending posterior to the vertebral body as well, so there's some intraspinal extension of this inflammatory process.
Some more imaging, MRI, looking at the different views.
Yeah, I think this is a MR of the thoracic spine showing some prevertebral inflammatory changes in the upper thoracic level, indicating more extensive infection. The vertebral end plates do not seem to be involved in this region. It's more prevertebral inflammatory changes.
So this kid had vertebral osteo, specifically involving coccygeomycosis. Osteo can present in an acute presentation or a chronic presentation. Most often it is caused from a hematogenous spread, although it can be caused by direct inoculation such as trauma or surgeries, and even from a local infection just spreading contiguous to the site where it is located. Staph aureus tends to be the most common. There are other etiologies as well that are by far much less common, but it's always something to think about. And then treatment has to be guided by suspected etiologies, but more specifically by cultures and biopsy results as well.
So for chronic low back pain that ends up being osteo, it's usually not going to be staph. It's going to be one of the indolent pathogens. And in Austin, we see cocci when it's dry. So we don't see a lot of cocci in years like this, but we had a run of cocci about 3 years ago when they were having a drought. But if you move anywhere west of here, you'll see cocci that's dry, except for the Pacific Northwest. And all throughout Arizona, New Mexico, and Southern California, there's a ton of cocci.
You don't have to have any specific exposure, like being on a farm or anything like that.
No, we used to ask, did you have a
Right.
farm raising,
Right.
or did your barn burn down? But no, if it's dry and you live somewhere where it exists, you're vulnerable. And it's just an airborne thing that happens to get hematogenous against but all the bugs that get into the spine that are slow movers are normal bugs. We don't see normal bugs. And then staph moves quickly, so it's not very subtle.
So with osteomyelitis, again, more than likely going to start off with plain films again to get a baseline and see exactly what's going on and if there's any concern moving on. Oftentimes with osteo specifically, you're going to want to get more fine detail of the soft tissue, the bone as well. And so MRI tends to be the study of choice. Doesn't require any radiation, sometimes requires sedation. And then again, the bone scan, specifically if you don't know where the source is located, then you can image multiple sites at once. And so that might be a time where that might be considered. So case number 3, so 8-year-old female, she's coming in with back pain for about 6 weeks. It's worsening, it's left-sided, wakes her up from sleep. On exam, just has some mild tenderness along the lower back, but otherwise it's pretty non-focal. And this is what you get. Does anyone on the left side of the room want to give a shot? My left side.
Well, that's exactly right. Again, what I try to do, I go up from the top, looking at the vertebral bodies, the disc, vertebral body disc, vertebral body disc, vertebral body disc, and then down here we see this vertebral body loses its normal structure. You see the anterior margin of the vertebral body here, and here it's all destroyed, and it's loss of height, and so suggests some sort of infiltrating process involving the L5 vertebral body. So the next step would be a MRI to look at this area. And you can see plain film's kind of pointy there, but the MR is a lot more sensitive. And so again, we see the normal vertebral bodies, and here we see the vertebral body is infiltrated on the T1 and on the T2. The disc is not involved. So again, tumor does not involve the disc where infection does. So this shows tumor involving the vertebral body, the loss of height of that vertebral body, collapse of that vertebral body, plus associated prevertebral extension of tumor and some epidural extension posteriorly from this tumor. And we're pretty good at seeing this, but we're not very specific, so it's up to the pathologist to give us the final diagnosis.
There's one more MRI.
And again, same sort of thing. This is a little bit off to the side, again showing this paravertebral soft tissue mass associated with the vertebral body infiltration and loss of height.
So this patient had Ewing sarcoma. So by far, this type of malignancy presents in the axial skeleton, more specifically the pelvis, and then also long bones, more specifically the femur. But it can occur in other locations. The also presents as soft tissue masses as well, not only involving bone and infiltration along that aspect as well, but it tends to involve the spine about 8% of the time. Typically, they'll have localized pain, localized swelling, and then you won't often, the majority of the time, see other constitutional symptoms that are associated with it. The concern, if there is concern for Ewing sarcoma, there is high concern for metastases, and so even early on you will get a CT of the chest just to make sure there's no subclinical or early signs of metastases, and then further imaging if that is followed by after the CT. On X-ray specifically, again, you will see potentially a soft tissue mass, similar to kind of how we saw on ours. And then you'll also see more of a destructive lesion where the margins are poorly demarcated, as well as a moth-eaten appearance. And then you may also see what they call a winking owl sign, so where you'll see one of the pedicles is not present compared to the other side. And then treatment often ends up being systemic chemo. So case 4, so we have a 16-year-old male presents with progressive low back pain, also right hip pain, severe. It's worse at rest, and it improves with activity. Uncomfortable with movement. he's tender along his low back, also tender along the right hip. There's pain with range of motion of that right hip, and then otherwise his back and his hip looks normal, and there's no neurodeficits on exam. And this is what you see on X-ray. Does anyone want to give a stab at it? Okay. Spine looks fused. They say bamboo spine.
That's exactly right. You see ossification of the paravertebral ligaments here, syndesmophytes, and also along the spinous processes here. This is called the dagger sign, and the whole thing is called the bamboo sign. If you also notice that the sacroiliac joints here are fused as well. There's some involvement of the hip joints. But sometimes you get like increased square appearance of the vertebral bodies. And of course, you all know this is Ankylosing Spondylitis. And again, sacroiliac joint is involved. And
So like he had mentioned, the dagger sign and as well as the bamboo sign that you'll see on X-ray, as well because of the inflammatory process, the corners will also seem more attenuated, and so you'll have a shiny corner, is what they call it, on X-ray as well that you will see. But it's one of the spondyloarthropathies, specifically associated with HLA-B27. By far most common along the adolescent age and among males. It's this chronic dull pain, and it's typical with other rheumatologic pathologies as well. So worse first thing in the morning, worse at rest, and then as the day goes on, it starts to improve as you become more active. Loss you could also have because of the fusion, because of the back pain, loss of mobility as well. A stiff back, and then treatment often ends up being supportive care, so rest, physical therapy, analgesic, specifically NSAIDs, and then as well disease-modifying anti-rheumatic drugs as well for this condition.
Do those kids end up from time to time getting MRs because of their back pain, or is it usually pretty obvious on the plain imaging?
Most of the time, what happens sometimes in these patients with what we call rigid spines, either from ankylosing spondylitis or severe degenerative changes in older age, is that if they're kind of prone to something called carrot stick fractures, and that the spine is so rigid, if there is a trauma or something, it will break like a carrot stick, and it can be very, very subtle on the plane films. So if you have somebody with a rigid spine and they had some sort of fall and they're having pain, the CT can be very subtle or it can be negative, and then an MR would be indicated there to make sure you don't see a fracture, because that's something you don't want to miss. If you miss it, then that fracture will become unstable and can lead to malpractice and bad things. So that's one thing you just want to be aware of with a rigid spine. It can be very subtle on plain film, even CT. If there's any question, MR.
Case number 5. So here we have a 10-year-old female. She's coming in again with low back pain. She fell on the playground, has worsening pain, but continues to walk. Mild tenderness over her mid-back, otherwise looks normal. No other deficits. And this is what you get on X-ray.
Is that the only image?
I'm afraid to go to the next one.
What if you look at that? Oh,
This one.
no, there's one more. I mean, that's my point, right? Is that
Yeah.
sometimes you'll get, I think you just asked for a lateral. If we call Dr. Leake and say, hey, look, I got that, I mean, he's good, but we're kind of stacking the odds against him, right? So you reap what you sow. So send that to the radiologist, and they're going to tell you, this is what I see. Will someone say something? Something. Thank you. Sean shoots his words again.
I see an X-ray of the spine. Clinical correlation required.
Is there anything else that you see that's abnormal or asymmetric already?
Or maybe not. Or maybe.
Non-specific bowel gas pattern.
Yeah.
No signs of obstruction.
The next one's empty, just has a lot of.
Yeah. All right. So we'll go to, and then we'll have Dr. Leake discuss both.
Thanks. Anybody see anything? I think you can appreciate here, I think that the height of the vertebral body is a little bit decreased compared to some of the adjacent ones. And particularly if you go from the lumbar area, it's more subtle, but there's some decreased loss of height of multiple vertebral bodies here. And so these are very mild compression fractures, and which in a child can sometimes be the first sign of leukemia or underlying malignancy, because they get diffuse osteoporosis and more prone to infect these fractures. Another thing, if they're on chronic steroids, they're more prone to subtle compression fractures, and then trauma, of course. But these can be quite subtle sometimes, and if there's any question, the next step would be MRI, or CT, and then if there's any question, MRI.
And so she had a compression fracture, and so collapse of the vertebrae, like you said, a loss of height associated with it, and again, trauma being the most common mechanism. And those kiddos, like he had mentioned, that are at risk for this presenting as a result of trauma or falling, kiddos with malignancy or tumor burden, as well as those with osteogenesis imperfecta and those that are on chronic steroids. And you'll see typically anteriorly a wedged shape deformity associated with it, in addition to the loss of height. And then unstable ones are ones that involve multiple levels. So there's multiple compression fractures. And then as well, if there's a greater than 50% loss of height associated with it, or there's a rotational deformity, then those are considered unstable compared to stable. The treatment is mostly supportive, so rest, pain control, as well as bracing, and then if needed, kyphoplasty, where they will inject bone cement into that vertebral body to help with pain relief. Okay. And last case, so 15-year-old female, she presents with low back pain for about 2 weeks, subject to fever, no trauma, weakness and difficulty walking, pain that radiates down her legs, no incontinence. She's been seen by her PCP, and these are the labs that they got. She's not pregnant. Anything else maybe concerning, not concerning with the labs? Yeah, everything listed, yeah. Yeah. So on physical exam, so she's in a wheelchair, can't ambulate, really doesn't want to move, can't move. Then you go straight to this imaging.
So I have a quick question. Would anyone have gotten plain films to start? Yeah. Dan says no. Dan Shipley's got an MRI.
I would order the MRI first.
I think generally, you start with plain films. If there's a neurologic deficit, though, MR would probably be the way to go, particularly if there's history and everything. And generally, if you're worried about infection, we do without and with contrast. So, this is a T1 weighted pulse sequence, and the grayish, this is the thecal sac here. And then around the L4 vertebral body level, this is the vertebral body. You can see the body and the vertebral end plates and the disc look intact, but posterior to that body, there's some inhomogeneous signal here, and the thecal sac itself is posteriorly displaced by this process in the ventral epidural space at L4 as well as L5, a little bit S1. Here's a T2 weighted pulse sequence. You can see the CSF is white here. We come down here, some nerve roots here. But again, there's a process posterior to the vertebral bodies, anterior to the thecal sac, displacing the thecal sac, and the ventral epidural space, L4, L5, a little bit of S1, showing inhomogeneous signal. And here it is on T2. Here's the vertebral body. And there's a process here, epidural collection. This is displacement of the thecal sac posteriorly. Again, the disc here looks intact, but there's a process, ventral epidural process, posteriorly displacing the thecal sac. And with that history and everything, you'd be worried, of course, about an epidural collection abscess.
And so this patient did have a spinal epidural abscess. Again, not super common, but kind of the classic triad that's associated with this is spine pain, fever, and then also having a neuro deficit. Once a motor deficit presents with this scenario, they often have residual weakness associated with it the majority of the time, as well as also having residual neuro deficits. A small percentage ends up being spread from local infection, but again, hematogenously can be spread, as well as direct inoculation from trauma, surgery, invasive procedures as well. And then by far most common, Staph aureus is going to be the etiology that is involved. The most common area that is involved are the regions. There's the thoracic and the lumbar regions specifically. And then MRI ends up being, like we had mentioned, going to be your imaging of choice when this is on your differential and you want to rule it out. But again, starting with plain films is very helpful and useful as well. CT, you may or may not see a fluid collection depending on the time of presentation, as well as whenever you're giving contrast, whether you see it being time dependent with that as well.